Good afternoon, everyone. We will be getting started in a little bit. I'm going to give it another minute, and then we will begin for any last-minute attendees joining. Okay, I have 12:32, so in the interest of time, I would like to begin our first bite-sized lecture of the year. Good afternoon, everyone. For those that don't know me, my name is Kyle Brown. I am a clinical pharmacist here at Piedmont Atlanta in Atlanta, Georgia. I serve as the bite-sized lecture coordinator for the Southeast chapter of FCCM. And before I introduce our speakers today, I would like to open up with our mission. To emulate the FCCM's mission, which is to secure the highest quality of care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. I'm excited to have our speakers today to share a truly once-in-a-lifetime experience with us. Today we'll have Ms. Barbara McLean and Dr. Marina Rabinovich to share a once-in-a-lifetime experience titled Into the Fire But Not the Field, Teaching Critical Care in the Ukraine. Dr. Rabinovich is a critical care clinical pharmacy specialist in the medical intensive care unit and director of PGY1 pharmacy residency program at Grady Health System in Atlanta, Georgia. In addition to being an active member of a multi-professional patient care team, Dr. Rabinovich is involved in training residents and students serving on the Residency Research Advisory Committee and is a co-director for the annual Southeast Critical Care Summit, organizing poster presentations and continued education for healthcare providers. She is actively involved in various research projects and quality improvement projects with a particular interest in sepsis care, glycemic control in critically ill patients, acute kidney injury, alcohol withdrawal, and management of pain, agitation, and delirium in ICU and post-ICU discharge. In collaboration with other providers, she initiated pharmacy services in the first multi-professional post-ICU care clinic in Georgia. She's also an active member of multiple committees at Grady, including Anticoagulation Management Team, the COVID Best Practice Committee, as well as Sepsis Care Committee, and is heavily involved in organizations at local and national levels, such as GSHP and SCCM. She is a past president of the Southeast chapter of the Society of Critical Care Medicine and continues to be actively involved, focusing on raising funds for Sepsis Alliance and promoting sepsis awareness via annual fundraising events and educational sessions. Ms. Barbara McLean has over 40 years of clinical practice in critical care. Currently, she is the Advancing Evidence-Based Practice Clinical Specialist for the Divisions of Critical Care at Grady Health System in Atlanta, Georgia. She is a distinguished member of the American Association of Critical Care Nurses, the American Association of Surgery and Trauma, and the Society of Critical Care Medicine. Barbara is renowned for her leadership and team building through education and community communication at Grady Health, earning accolades including the Excellence in Education by the AACN, the Circle of Excellence for Clinical Practice by AACN, and recipient of the prestigious FCCM Norma J. Shoemaker Award for Critical Care Nursing Excellence. In 2017, she was also the first nurse ever to receive the Joseph A. Brown Award for the Society of Critical Care Medicine for her contributions to critical care practice. In 1994, Barbara became the first nurse and nurse lecturer and course director for the Fundamentals in Critical Care Support Program. She has since written 24 chapters, 18 articles, and even served as the editor for the 4th edition of the Fundamentals in Critical Care Medicine text. Her influence extends through her active YouTube channel, which has numerous presentations and global outreach, as well as mentorship in hemodynamics and sepsis management. Her research has been focused on blood flow and oxygenation, and she continues to expand her knowledge every day in her local and international clinical practice. Her dedication to humanitarian efforts include independent volunteer work in healthcare development and direct patient care. Barbara was one of the first responders at the Houston Astro Arena on day one of evacuation following Hurricane Katrina. Over the years, her efforts have extended globally to Nicaragua, Tanzania, Haiti, and most recently, the Ukraine. Barbara's pivotal roles in disaster management underscore her commitment to global healthcare. She is a sought-after speaker for many international critical care venues based on her experience and expertise. As an educator, provider, and practitioner, she is committed to patient care and safety, critical care practice, collegial communication, evidence-based practice at the bedside. With that, I would love to hand it over to our speakers today. Thank you.
Thank you so much, Kyle. We're really honored to be here today, and we hope that we're going to be able to share somewhat of our experience and our practice when we were working together in the Ukraine. We were really fortunate to be together, and you can see we're both representing the Ukraine here with our Ukrainian shirts. And again, thank you very much for having us. So just as a, sorry. Okay, so just to begin, I just want to remind everyone of the philosophy of the FCCS, which of course stands for Fundamentals in Critical Care Support. And the basic tenure of the course is that it provides healthcare professionals with the training for management of critical patients for the first 24 hours. Now that was really what the initial evolution of FCCS was to provide training for non-critical care personnel to stabilize and manage patients for 24 hours until they could actually receive or transfer appropriate critical care consultation or critical care services. But of course, we all know it's grown way beyond that. This is now really the premier course for training residents, APPs, nurses, pharmacists, respiratory therapists, and indeed physicians worldwide in methodologies of managing critical patients. So the first course was actually launched in 1996, and that course in 1996 was exclusive to physicians only. In 1998, I went on a van with 3 of my physician colleagues, 2 attendings, and a fellow. We went to Nashville, Tennessee, where I basically insisted that they allow me to take the course. Nurses and non-physicians were not actually facilitated, but I did take the course and I passed the physician test. 2000, FCCS opened up to non-physicians in the United States, and in 2004 opened to non-physicians worldwide. So initially it was a primarily physician medical course that is now opened into many other areas, and it's dominoed into multiple courses, but most particularly pediatric FCCS, FCCS surgical, FCCS obstetrics, crisis management, and resource limited. So it continues to evolve and move forward. Just thought you might like to see the picture. This is me, of course, and SCCM, as much as I adore them and as much as I've been involved, they've never gotten my initials right. And because they're primarily a physician organization, they're like, why do you need all those initials anyway? But you'll see this was my first pass at the FCCS course. I then became the editor and also the FCCS chairperson, the first nurse, actually the first non-physician international course consultant, and the editor in that edition, which was January 2007. And of course, FCCS is now in its 7th edition, so 3 editions later, and published in 12 languages. Now, I want to start off with introducing the FCCS surgical team. We were 2 different teams, FCCS surgical and FCCS ICU liberation. So I'm introducing this team. I'm not going to give everyone's name because that will take a lot of time, but I do want to make sure that we honor in the center Mary Jane Reed, who's a trauma surgeon from Geisinger Hospital in Western Pennsylvania. And MJ and I have worked together in FCCS and in other projects through the society for about 12 to 15 years. We also, in this picture, there are 2 translators. We'll introduce them more a bit later, but this gave you an idea of our team, which was small, dedicated, and basically we were working 14 to 15 hours a day when we were together in the Ukraine. So take it away, Marina.
Hi, everyone. So I was part of an ICU liberation team, and ICU liberation campaign launched about over a decade ago by FCCM with the goal to reduce harm to patients from ICU stay. It is focused on a multi-professional approach to managing patients' pain, agitation, sedation, preventing delirium, and improving their mobility and exercise, and basically getting them in ICU as fast as possible, and has shown that implementation of even in just any parts of the bundle, if not all, would still decrease complications that could be acquired. So while it wasn't, is not a new concept to us here in US, it is somewhat of a novel approach for people in the Ukraine. So it is something that they requested that we review with them, train them on different parts of the bundle of the ICU liberation, and help them with the throughput in the ICU. And that it is our team, the ICU liberation team that went to Ukraine, consisted of physician, our leader, and a couple of pharmacists, and respiratory therapists, and physical therapists.
All right, so just to talk really quickly, I am always ready to go to any situation that could require education or just basic support in critical care. And I had been trying to get to the Ukraine. I was communicating a lot with Marina. Marina hooked me up with people. Other folks that I knew hooked me up with people, trying to go to the Ukraine, made endless calls, lots of connections, and had multiple failures. Just couldn't find a way to get there and be connected. I'm not a person who's just getting off the plane going to do something, especially in a war-torn area. But finally, MJ Reed called me because we'd worked together a lot before. She is assisting me in an organization to go to the Sudan and to run a critical care nursing course there. And we've known each other for quite a while. And I said, as soon as she called me, yes. And I immediately called Marina and said, Marina, there's an opportunity to go to the Ukraine, and it's with FCCS, and can you go? And then, of course, we had quite a bit of consternation with our families. They were very worried, but we worked that out. Both of us together, we made a commitment that we'd be sure we were safe, and followed through with that. It was fantastic. And so very, very fortunately, we got Marina.
And for me, of course, it was somewhat of a no-brainer since I was born in Ukraine, and but it had been 27 years since I've been back. So this was definitely a call kind of to return back to homeland and give back to my community. So appreciated the call.
So the FCCM, actually, they call this hosted courses. Hosted courses include ICU liberation and all of the portal of the FCCS and other courses. Just now, they're calling for volunteers for mechanical ventilation, airway management, but it's an ideal menu for critical care in the Ukraine. The intensive care units during the Ukraine war were experiencing terrific challenges, and of course, that's an opportunity as well. They really it's a very different practice. So, you know, FCCM today is different than FCCM was 20 years ago. FCCM today is completely focused on multi-professional practice. And in other countries, in the Ukraine as a representation, but many other countries, it is primarily physician-driven. You may not have respiratory therapists. You may only have one pharmacist. Nurses typically do not have autonomy, and they may not have a very high level of education. So So there were lots of opportunities to explore, to project what a multi-professional practice was. And the initial communication began from an NGO known as Direct Relief. Direct Relief contacted the FCCM and organized between the FCCM and the chief anesthesiologist at a major hospital in Lviv to put these thoughts and possibilities and capabilities together. So Direct Relief and SACM brought the whole portal for evaluation to the chief anesthesiologist, who then made decisions and picked and chose what she would like to have for her group based on what she felt the needs were. And that decision actually was to incorporate really the full ICU liberation and then just parts and parcels of FCCS surgery. So FCCS surgery talks a lot about surgical techniques and procedures, problems and processes, but it also incorporates a lot of the standard of FCCS, things like sepsis and sepsis management, airway management, mechanical ventilation, hemodynamics. So following the basic format of a small point-of-care ultrasound program that was developed and utilized in the same hospital in Lviv in March of 2023, we made these organizations of our teams for FCCS surgical, as I've already mentioned, and ICU liberation, the full course for ICU liberation. And the decision was made to run 2-day courses. So simultaneously ICU liberation and FCCS surgical, and then transitioning. So group 1 did ICU liberation and then moved over to FCCS surgical. So they were there for 4 full days. And that meant that we would repeat our courses, and we did a total of 4 times each. So that was really very significant, 4 times each for each group. So 4 days each, I guess, for each group, 4 total times. So that was 8 days total of education. All the slides were translated, and translators were provided for all the lecturers. Now, we're very fortunate because, of course, we have Marina, and some of the residents were very, very experienced in English. One of the translators was very experienced in English, but the rest of the individuals were at different levels of expertise in medical translation. So that, of course, offered a little bit of, just a little bit of a challenge, which we, of course, were able to overcome. And sometimes you would have a resident in your training and you had a translator, and the resident would say, no, that's not at all what she said. So that was really good to have that. So we went to Chicago in late July. This is us in Chicago, and we're in front of our abdominal skill station slide. Some of us knew each other. Certainly I knew Marina. I had worked with Christine Perma, a physical therapist, some 25 years ago. She was a featured lecturer at a program I hosted, and I knew a few of the other folks on the team. But in general, most of us didn't know each other. And if we did, it was mostly because we had presented FCCS courses together. Of course, Marina and I worked together, so we know each other pretty well. But it was mostly all new recruits to this program and new friendships, even though every individual who was involved was very, very experienced. They may not have been that experienced in FCCS, and it brought us all together in new friendships. Do you want to take this one?
Sure. The planning started in way earlier than that, of course, in April or May, and then the team was recruited sometime in June or so. And as Barbara said, we met in July to go over all of the required training and documents. We did lose some members of the team because in the weeks preceding to our departure day, there were a lot of rising conflicts and airstrike alerts close by to where we would be stationed. So that was understandable, but FCCM did an excellent job providing us with a reassurance for safety and constant communication with the State Department and the mayor of the city that we were stationed in. They basically provide us daily updates on whether or not, and all of us were always felt like we could leave this mission if we felt unsafe. But I think 90% of us ended up proceeding with the mission. We're very excited with it.
So you can see here with the red circle, this is where Lviv is, and you can see it's relatively close to the Polish border. And so one of the things that was assuring to us is that missiles that were being fired, planes that were moving forward at that time were being deployed from the far east side, and we were on the far west side. So we felt pretty good about that. And you see below here, this is a text message from our FCCM group leader, that would be Brian Schramm, just letting us know that he's on top of it. They're communicating with the State Department, and we would get updates all the time to say whether or not they thought it was safe. And we did have the possibility to have a virtual option. Marina and I flew in 2 days early. We spent 2 days in Krakow, and we met with one of her colleagues who had actually been evacuated from the Ukraine through her beneficence and her friends and colleagues who assisted her friend. And this just shows us, we met in Krakow at the airport. We boarded a bus. It's a very nice bus, as you can see. And folks were in various states of exhaustion. We had already been there 2 days. So you can see we were pretty energetic. Everybody else is kind of sort of sleepy. And we traveled to the border, and it took 6 hours, including the crossing, because the crossing took about 2 hours on our way across the border into the Ukraine. But 6 hours, and then we arrive in beautiful Lviv. So in the first morning, we're going to get up and go to the hospital, and we're just showing you just kind of a basic visualization of the beauty of Lviv. This is a painted map that is in a small old underbridge, beautiful, beautiful area, City Hall, the Opera House. First morning, we got to get to the hospital. We're going to go to the hospital and get set up.
So we were stationed in the main regional referral center, their main hospital, basically for a pretty large region. They became their main COVID hospital during the pandemic, and now during the war, they're the primary post-war center as well. It's a very large hospital, 1,200 beds, but the capacity has been increased to up to 1,500 during the war. They had a children ward, and they had a ECMO. They were able to provide various levels of acute care, including CRT and ECMO, as we already mentioned. But the problem initially was that, they lost a lot of staff, as a residual from COVID pandemic, and now the war. They were operating on very, very limited number of providers, and especially nurses, and just in general front lines. They were at war. I mean, some of the providers were at war, actually actively fighting, and some just were not able to continue. So there was we did have to pivot a little bit and adjust how we approach our training in almost kind of like resource limited situations, even though they had the equipment. They may not have people to operate the equipment. So, and we'll talk about it some more. Another huge part of the hospital was their rehabilitation center, which was a beautiful facility that was built to help rehab the so anybody post-war, anybody injured in the war, or any victims of the war. We had the opportunity to go over there as well and assist them with some of their procedures and workflow, but then visit some of the patients as well. All of the healthcare providers there were very willing to learn from us, so that was also very welcoming, and they really wanted to learn the best that they could do for their patients.
So this is just a short video.
Ukrainian Ministry of Health, and in particular, the Vice Minister of Health. That is, he's an anesthesiologist himself, and tomorrow he's gonna come here.
І завтра буде в обідню частину, офіційна частина урочисте відкриття із представниками мерії і представниками адміністрації міста Львова.
So this is just to show you, this is the chief anesthesiologist. She's really the planner and the moderator and the organizer. And this is our main translator who's very, very experienced in English. He just recently lost some of his colleagues in the war. His brother had just been deployed to the front. He's also worried about being deployed to the front, but he was fantastic. He became really our brother during this time period. So I just wanted to show you, this is really just on our day one, our setup, the introductions and preparations, recognizing how important this is. The mayor is coming, the Minister of Defense, the Minister of Health are all going to come on day one, and we're just getting prepared for that. And then we took a tour into the hospital bomb shelter, just to be aware of how to get there. We unfortunately would have had to leave the area, go outside and go to the bomb shelter, which we never had to do. We just had a basic view of it. There were other things that we might have been able to show you, but we were asked not to take any pictures, but you can just see it's very well planned with hospital beds and with gas masks, etc. So we were feeling quite safe. We felt like this was going to be safe. Back to the hotel we go, and at 4 a.m., that's day 2, but it's our first course day. We get an air alert, and it's our first air alert while we're there, and we don't know anything. So we all go down however many flights of steps. For me, it was 5 flights. I think for you, it was 3 or 4 that get down to the bomb shelter. The thing about our hotel is that it had the most luxurious indoor pool with 14 different types of jets, 3 different types of saunas, 2 different types of steam baths, and on the side of that is the bomb shelter, and that's where we are. Don't worry, Marina was okay. She was in another part of the bomb shelter because she was already up exercising. So, oh my God, she's so crazy. But this is our basic first experience with the bomb shelter. And there were many things that were occurring. And I'm not saying this is necessarily that time, but that MiG fighter jets were becoming more and more frequent, and that provokes air alarms. They may or may not get close to us, but we didn't really know. We were advised by our leader, MJ, that when we got an alert, we should always go to the bomb shelter because we didn't really know if things were going to actually reach us, if Lviv was a target or not. Even though it's on the western side, there is always that possibility. Okay. So as we mentioned before, 2-day courses repeated 4 times, right? 500 participants overall. Those numbers vary. The report one time was 480. The FCCM report was 370. It felt like there were 500 people overall. And again, we really never, except for Marina, we never really knew what our translation was, or if they were really clear in our translation. And we also lost some of our translators because they just couldn't keep up. We had some translators that were there for half a day, and then they just said, we can't keep up with this medical lingo, we gotta go. All the participants received a tablet, and on the tablet were all the translated slides. Now, if you know about FCCS, you are not supposed to deviate particularly from the slides. I think ICU Liberation is a little less formal. I also changed a few of my slides, so that made it particularly strenuous for my translator. Plus, I never follow a slide. I never met a slide I liked, so I didn't really follow my slides, and that made it kind of stressful. They kept having to give me a different translator every day because I think I gave everybody an ulcer, I'm pretty sure. Okay, and we gave them all access to FCCM resources. We gave everyone a membership, and we all created connections for ongoing learning. So now is our first course, first day, and here is going to be the Minister of Health and the Minister of Defense, and again, our anesthesiology lead. So we just wanted to show you that. So now let's talk about ICU Liberation.
So yeah, jumping into our courses, specifics on the courses. So ICU Liberation course, we wanted to review all of the components of the bundle with them. Again, this was a very relatively new concept for the healthcare providers in Ukraine. Day one was heavily mostly didactic lectures on different components, A, B, C, D, E, F, and implementation of those components. And then day 2 was mostly hands-on demonstrations and simulations and kind of just how to implement those bundles. So in these pictures you see somewhere we utilized live audience, we utilized our audience as our patients. We had all of the setups, ventilators, ET tubes, tubes and lines, chest tubes. We tried to make it as real as possible with a hospital bed so that the providers from Ukraine could kind of feel and see what would it be like if we had the patient like that in the ICU. I'll briefly go over different components of the bundle and kind of what we did. So the first time we did the training, the ICU liberation training, really didn't know what to expect, because again, we didn't really know how much they knew about ICU liberation and each component of this bundle and what their practice looked like. To be honest, we did have to pivot quite a bit after our first day, because we realized that our approach to ICU care might be somewhat different than theirs. And as Barbara said, FCCM is very focused on multi-professional approach to implementation of each component of ICU liberation. Well, we quickly realized that a lot of their care is driven by a physician who is an anesthesiologist usually. Nurses have very little involvement in day-to-day plan of care aside from just doing what they're kind of told. They don't really manage medications or drips or and such, and there's no respiratory therapist. There's very limited number of physical therapists out there. So we kind of had to change it up a little bit and how we're gonna help them implement what we're trying to teach. We quickly realized that they weren't really aware of behavioral pain scales when we were teaching about analgesia. Very limited use of opioids outside of the OR. That was like the most commonly asked question. Are you really using fentanyl as in your ICUs? What are you doing? That's crazy. They were very, very surprised at the amount of opioids we use here, which is understandable. And we took away a lot of good lessons from them too. They mostly use regional analgesia, and all of their patients are basically on scheduled acetaminophen or an NSAID type of medication or an aspirin-like medication for pain. It was a very hot topic, analgesia, opioid use specifically. Josh Balsane was our leader, who is a pulmonologist, and he spent most of his time on the SBTs and kind of how to get patients off the ventilator. Again, the challenge was that they do not have respiratory therapists. So the physicians are the ones who are managing the ventilators. And while they had most of the modern equipment, and some of their ventilators were even better than what we have at our hospital, they really weren't utilizing them at full capacity. So they weren't really utilizing a lot of their SBT modes, different modes of the ventilator can do. So there was a lot of opportunity there for teaching. And most of their patients were trached early, so there was very little room for, I guess, SBTs and getting them trained on that. But they were able to provide a lot of good insight. And the family part was also a little bit challenging. While family was included at the bedside and provided a lot of nursing care, actually, a lot of nursing care was given by the family.
Physical care.
Yes.
Physical care,
yes.
different than nursing
Right,
care.
Sure. They were rarely included in the plan of care discussion. So they were mostly there to support their loved ones and do some of the kind of like day-to-day activities, but not really as included in plan.
So probably a really important thing to note is if you ever have the opportunity to go anywhere outside of the United States, except in England, pretty much European, African, Asian, Pan-Asian practice, nurses have a very limited role. Nurses actually will do what's been told by the physician. They don't actually participate in rounds, and families do a lot of the physical care of the patient, the bathing, etc.
Yes.
So it's really, that's actually quite common outside of the United States.
sedation and delirium was also very eye-opening for us and for them. They were terrified of using propofol and dexmedetomidine outside the OR. There were a lot of concerns about side effects associated with both of those agents and how do we handle those side effects on day-to-day basis, monitoring involved with that. Their drug of choice for sedation, believe it or not, is thiopentol. Very widespread use of thiopentol for sedation. So it gave us a lot of opportunity here for education about ICU delirium, how to diagnose, how to prevent if possible, and what to do if patient is diagnosed with delirium, and how we could manage those patients. So there's a lot of good discussion with this topic. Very engaging.
Mobilize now.
Letter
Hands up. And to the beat, start jumping, bouncing.
This was the most engaging part of the day. Early mobility, we were able to do a lot of hands-on. You can see here, we got everybody to get up and mobilize a little bit every day. So it was great. It was a lot of fun having a very exceptional team of physical therapists who are experts in their field. As you can see here, our physical therapist played a patient and talked while she was being, intubated and such. But we did a lot of hands-on here. Day 2 was great, and with their state-of-the-art equipment in their rehab center, as you can see in the picture here, they even have a walkbot, which is like something that only a few centers in US have. They rarely utilize their equipment. So they had a lot of good equipment, but they really just had limited knowledge of how to use it. So that's where we were able to help out a lot.
So I'm just going to mention something about Christina Perma. As I mentioned, about 25 years ago, I invited her to speak at a conference that I was offering. And at that time, she was a renegade because she was a physical therapist already talking about mobilization and movement off the ventilator. And she published quite a bit and became very, very well known. So a lot of her work is included in the ICU Liberation. Also the work of, I think we'd be amiss not to mention Wes Ely in ICU Liberation, because he really was, as most of us know, we all admire him so much, but he was actually one of the progenitors really of ICU Liberation and looking at, certainly looking at CAM ICU and other methodologies.
And they had a lot of work going to rehabbing after patients left the ICU or the hospital, but what they really took away from this course is how to start rehab early while the patients are still in the hospital and the ICU, and they had no concept of that. So this was definitely something that they took away from this course.
All right, well, I'm not going to be quite as prolific when I talk about FCCS surgery. I will say this, in 2006, the first time I went to Tanzania, I went there the first time to work with an FCCS course that was sponsored there. And that was probably the first time that I recognized that FCCS, while fantastically organized and really beautifully conceptual, did not really apply in resource limited environments or war-torn environments or disaster states, because a lot of what's talked about is incorporating kind of higher level concepts and a multi-professional team. So knowing that as you're going into the course, that you've got to be really flexible and you have to be able to kind of fly. I call it FCCS surgery on the fly, because you have to be able to change how you're speaking to adapt. And as Marina said, day 1, we didn't really know that. By our second course, we were pros. We had changed a lot of what we were saying and a lot of what we were doing. The FCCS surgical course is a didactic course followed by small hands-on skilled workshops, but we didn't have the same kinds of skills that you have in ICU Liberation, where you're looking at physical therapy, etc. We're talking about vent modality. What do you want to do? What does this show you? Talking about hemodynamics in small stations. So they were case study based small stations, but we didn't actually have much hands-on. So that it was a little bit different, because normally in FCCS you have your skill stations where people have an experience with hands-on approach, that was a little bit harder. We all had ventilators, we had hemodynamic capabilities, but actually hemodynamics as we know it, which is primarily, even if it's minimally invasive, like with POCUS or with echocardiogram, or maybe you're using a Starling, and then minimal with an A-line and a CVP to maximal PA catheter, really they didn't have these things. So again, you kind of had to be able to work on the fly. So again, I want to just give credence to our leader, MJ Reed. She's fantastic. If you ever have an opportunity to work with her or go to a course where she's involved, she is fantastic. She's quite a legend in FCCM because she's been involved for such a long time. But she was a very different leader than Just Ball. The ICU Lib folks had a lot of free time. They did a lot of dancing and singing. We did some dancing and singing, but not while we were at work, because MJ was the taskmaster. That first night when we got there, Marina organized this whole wonderful dinner event, and MJ said, you guys cannot go to dinner, you have to review your slides with the translator. So we sat there, actually myself and one other person, for 4 hours, and then at the end of 4 hours they said, well, we don't have time to review your slides. Darn, I missed that dinner with Marina at that fantastic restaurant. She is a hard worker. She's always working. She was always completely prepared for anything that could go right or wrong, and she was always looking out for our safety. Remember, I told you that she said, even though folks may say you don't need to go to the bomb shelter, it really probably isn't a significant alert. If we get an air alert, we're all going to the bomb shelter. She was always looking out for our safety, making sure everybody felt involved, making sure everybody had a meal and that they weren't alone, that they had somebody to be with and go places with. So she was pretty fantastic. Okay, so as I said, this is really surgery on the fly. You had to really do on-the-fly adaptation, which made it difficult for the translators because the slides had already been pre-translated and pre-published. And here you are, you're saying, okay, well, I already knew this might be an issue because I've done remote courses or resource poor courses before, like talking about hemodynamics and an A-line and a CVP and an SVO2 or an SCVO2, that may not be very meaningful. So I had to say, okay, everybody, does everybody have this kind of monitor or that kind of monitor? Okay, on that kind of monitor, you can actually do something called perfusion index, which is going to give you some hemodynamic value. And that was really difficult, I think. Unfortunately, I felt quite badly that it was really difficult for the translator because it had nothing to do with what was on the slide, but everything to do with what it was that they needed to know. So you can see me here. This is a skill station on hemodynamics. I also ran the skill station on mechanical ventilation along with other people. We had multiple skill stations. And here is Mark Hamill, who's a very well-known trauma surgeon. He actually is also can sing in the voice of Frank Sinatra, because by the way, we did go to karaoke in the Ukraine. We did go to karaoke and we learned that he was a fantastic singer, and he was also once an NYPD officer. So he had a lot of knowledge about trauma, how to create it, how to fix it, both of those things. And this just shows you again, kind of our teams and our team in the back of the conference room. So ICU Liberation got a beautiful state-of-the-art theater. We were in the gym. So, and that was okay, because you know what, you always adapt. At first we said, we're going to transition. We'll get the theater for some time and you'll have the gym. But then we just said, nah, we'll just keep the gym, no problem. And you can see where these are all the instructors. They're either reviewing their lecture or checking their email. And over here, of course, is our wonderful translator. And then again, here we are as a team and with some of our attendees and skill stations again. Okay, so lots of discussion about abdominal sepsis and antibiotic utilization. We unfortunately didn't have Marina in this session. You came in one time, you did. But in the first session, I think, or maybe the second session, Heather, who is a PA, was talking about abdominal sepsis and just probably struggling a little bit because the antibiotics, although they might be very similar, even the same, we weren't able, she wasn't able to communicate that.
The biggest concern they have actually as far as abdominal sepsis or infectious control in general in that hospital is it's just infection control. So they are seeing enormous amount of multi-drug resistant organisms in their study because they are the main combat hospital. they're seeing war victims coming from all over the country. And they're coming from many different regional hospitals where they were given numerous other antibiotics and their infections are not well controlled. So by the time they get to this trauma hospital, they're coming in with extremely resistant organisms, and they are they're struggling with antibiotic exposure and then duration of antibiotic overuse of antibiotics and such. So we actually had a chance to help them with some of the patients, review their cultures, review their previous antibiotic history, and kind of guide them through avoidance of certain antibiotics and what would be the most appropriate durations and such. We met one and only clinical pharmacist for the whole hospital of 1,200 beds, who was basically charged with the antibiotic stewardship role to try to minimize antibiotic overuse and decrease their MDROs. But that was a huge challenge for them, yes.
It was a huge challenge, and in retrospect, next time we would have a pharmacist do this lecture because we needed somebody to be facile about that. And she certainly knew about antibiotics and antibiotic resistance, but it would have been, and we were always very helpful to have Marina, but it was very challenging. And then lots of discussion. I showed you this just to show you the slides are all translated. At some point, we basically remembered that we needed to have our own slides, so we knew what slide we were on, what was on the slide. And over here, you're seeing that we have a translator and we have a resident next to her. The translator was not a medical translator. She really struggled. She left after the first day, and that resident then became a primary translator for us. He was quite facile in interpretation. This is one of our pulmonologists who works in long-term care and actually operates a series of LTACs in Florida. So he adjusted his talk to really be about long-term management, and in particular, talking about tracheostomy and tracheotomy management, which was not part of the slides, again, made things a little more difficult. But
that's what they see.
That's what they needed, but we didn't know that when we got there. So again, our course continued to evolve as we were going forward. We had a very nice celebration here. This is a place where you actually can shoot an air rifle at a picture of somebody who people didn't like. Let me just say it that way. Somebody people didn't like, and we were all there. This was our FCCS surgery group. This was one night that we went out ourselves. I, of course, was very focused on hemodynamics and talking about hemodynamics overall. This is not in the Ukraine. This is in our practice session in Chicago, because in my group, I was the person who was taking photographs, and I wasn't doing that great of a job. In Marina's group, they had a person who took beautiful photographs, and a lot of them. So I don't really have any photographs of myself, so I put this one up here. But this is my group as they are listening to me discuss how do you actually optimize hemodynamics with what you have. So I talked a lot about perfusion index. I talked about comparative analysis of the ABG and the VBG, and particularly looking at PVA-CO2 as an endpoint to tell you if your patient needs volume or they might need an inotrope. I did have an occasional, and in the last group, I had a pediatric cardiothoracic surgeon. All of his patients had PA catheters. He had lots of things to add about SVO2. We had a fantastic 35-minute discussion after my lecture talking about how I look at optimization of oxygen delivery, but in general, just really trying to instill something that's simple pleth, simple blood gas. They all are looking at blood gases, actually helping them to understand blood gas interpretation. So really off book with what a lot of the slides were sharing with us. And then we would come together frequently. We came together to just have some discussions. Oftentimes we'd have individuals who were important who were coming to see us, and that happened throughout the course. Sometimes that threw us off schedule. It's very different than in the United States, and this is an experience that I have everywhere I go outside of the United States. Nobody is keeping time. They don't care. they're there to learn. Okay, you lose an hour because the defense minister comes and talks, and he talks, and then he has to be translated, and then we have questions and answers. So now we're an hour later. Nobody cared. They all came there for learning. They would have stayed till 9 o'clock at night, I'm quite positive. We ended up by around 6 or 6:30 or 7, we were pretty exhausted. So, you know, it's quite strenuous. So all of us are experienced speakers, but it's quite strenuous to speak and then have a translator to keep your energy up. You say something, the translator has to translate. You're trying to keep up your same level of energy, and everybody did a good job at that. But it requires a lot of effort. Okay, and so then again, I'm just going to show you again this picture you've already seen. This was one of our main translators. This was the head translator, and again, the FCCS group. And over to the left, some of the advanced students and the residents that we were working with in FCCS. So Marina, take it away.
So thank you. And we did have a chance to go to the bedside, which was pretty amazing, and get to see some of the how patients were managed in the ICU and outside of the ICU. We even one of our respiratory therapists was able to even help them with change in ventilator settings. They were able to help them extubate patients, several patients on one day, put patients on SBT and liberating them. We were able to walk patients, help them with pain management and antibiotics management again. So that was a really great experience. We met the clinical pharmacist, the one clinical pharmacist they had for the whole hospital, and shared some of the protocols that they could potentially utilize.
Again, there was a little bit more free time with the ICU liberation group. So the FCCS surgical group didn't get to participate as much on rounds, but then we did rounds again so that we could actually observe the participants actually practicing what they've learned. And so at the bedside, I was really fortunate just in that short time to actually turn on perfusion index, show them what that was, how that could help them to understand blood flow dynamics for their patients in a non-invasive way. But they were practicing physical therapy, they were practicing evaluation of CAM ICU and basic critical care pain assessment or observation tools. So that was really nice to see them practice what they had learned.
Of course, as a pharmacist, we have to show you what the pharmacy looks like. It's a very different setup for those who are the pharmacists on the line. Their main pharmacy, hospital pharmacy, serves more of like a warehouse of medications where the nurses call down and say, we need this supply of medications, and pharmacy sends it up. The pharmacy that is pictured here where I'm posing is an outpatient pharmacy. This is the hospital pharmacy, but it's set up more of an outpatient a setup where patient's family may be given a prescription for something that they don't have in the hospital. They can walk over to this hospital pharmacy and fill that prescription for the medication that their their loved one needs while they're in the hospital. So an example, if the patient has a multi-drug resistant infection and they need an extended spectrum antibiotic like Zerbaxa or Avicaz, they don't carry that in the hospital. The provider will write them a prescription for Avicaz. They would walk it over to this pharmacy right here where I'm posing, and they would fill it there with their own money or whatnot, and would have to bring it back to the hospital for the nurse to administer. The picture here on the right is their Pyxis. I'm standing in front of what quote unquote is Pyxis, basically, which is a closet you open, and the medications are basically just on the shelf. And if you keep going, I have some examples of that. This is their syringe pump setup. One of those syringes is thiopentol, for example. This is again the closet with medications where, as you can see, there's no differentiation of medications, no sound alike, look alike, or separation. So kind of like a nightmare for any pharmacist and medication safety component. But as you can see here, there's, if you look closely, there's the norepinephrine and epinephrine right next to each other, right next to dexmedetomidine. So they had pretty much most of the medications we use here. Some of the names were a little different, but as far as sedatives and analgesics and antibiotics are all very, very similar. We have meropenem here, right on top of there is ceftazidime and ceftriaxone, piperacillin, tazobactam, omeprazole, enoxaparin, all of the same medications. And another like really awesome thing we got to do at the end is we were able to walk over there to their blood center and actually donate blood for their trauma and for the victims and such. So that was a really cool and rewarding experience.
And those of us from FCCS surgery wanted to donate blood, but we would have had to do it after operational hours because we had a taskmaster and we weren't allowed to leave. All right, well, this is really important to say that the reality for participants, of course, is quite different. The people that were in our course, they had lost homes, they'd lost families, they had maimed loved ones, they themselves had served at the front. They did not take a lot of pictures because of fear of retribution. Spy, Marina and Joanna, both pharmacists, were taking some pictures and were actually initially mistaken for spies. So folks were kind of worried about that. Didn't really want to use their phone because they often need their phone battery to be flashlight. Lots of error alerts going on, kind of scared us in the beginning. After that, we were pretty nonchalant. But it was also important to remember that this had been going on for 2 years for all of our participants. And many of them were pulled from hospitals and practices at the front lines. They came while their colleagues covered, then they went home, and the colleagues who were covering came to the program. So that's very frequently what you'll see kind of in a disaster and resource disaster and war-torn nations, is that's always kind of a shared relationship. Many of them felt very ill-equipped to perform their duties. They just don't have a high level of training. Nurses in Ukraine do not have a high level of training, but nurses worldwide don't necessarily have autonomy, even though they may have baccalaureate and master's degrees, some of them doctoral degrees. They don't really have the same kind of autonomy that nurses in the United States do. Lots of stories were shared, and it was really important to visualize everywhere we went. We could visualize signs of patriotism, honor, glory for what was occurring. Towards the end of our trip, we had a very fabulous dinner at a historic Grand Cafe, beautiful local food, lots of discussion about how we had changed their practice, that they were so thankful for us, that we all felt a sense of accomplishment as they did, and we really felt honored, blessed, and privileged. But there was some time for fun and celebration. Marina and Joanna, we had one day, one free day the whole time that we were there, but Marina and Joanna, because they're PharmDs, they can't really take a day off. They ran a marathon and raised money, half marathon. Oh my God, it still seems like a marathon to me. But we did have a lot of fun. I mean, we had a lot of fun on that day. We packed it in. We visited a historic pharmacy. And by the way, Marina's anniversary happened while we were there. Her husband reached out to me and said, listen, can you go and pay for these flowers? Because I don't know how to do it. I've ordered them, make sure they get put in her room, and just pay for them and I'll pay you back. I'm still waiting for that check.
Oh, wow.
No, I'm only kidding you. Don't worry about that. You bought me my
Apparently
beautiful.
he did tell him to write, he gave him a note in Ukrainian to write, but it sounds like they corrected a lot of his Ukrainian, so he was pretty upset about that. But
it may have said something different, but obviously the flowers express love and adoration. And in the end, it was really wonderful. We got this note that says, I'm extremely thankful for such a way of information provision. I took a lot of new and interesting things into account. I'm grateful to you that despite the war in our country, you were not afraid to come. Glory to Ukraine, Slavi Ukraini. And Slava Ukraini. You can correct me because I don't say it right. And this is the residents and the anesthesiologists forming a line in front of our bus to prevent us from leaving. And here we all are together. And just a little dance that they did for us as well to say goodbye to us as we were leaving. And on our last night, so this is us leaving, you can see Jaspal, all that dancing. He slept on the bus. Our SCCM folks were kind of tired. Marina's still pretty happy, but she's also pretty tired. But on our last night, we were in the Hilton Garden Inn at the Krakow airport. when who should we meet but Jose Andreas, who had just come back from the front where he was operating a kitchen. As if you know who Jose Andreas was or is, he operates kitchens in disaster areas and war-torn areas. You might also remember he was operating a kitchen in Palestine, and he lost quite a few of his colleagues there. But he also lost some colleagues in Ukraine. Yes. He shared with us he lost five people in Ukraine, but he continues to do his humanitarian mission. We offered him a honey vodka. It was Marina, myself, Jason the Stam, and MJ Reed, just the four of us, because we were the only ones awake at 2:30, because we had to get up at 4 anyway, so we just drank vodka. And we offered him a drink. He didn't partake, but he stayed and talked with us for quite a while. And this is our beautiful SCCM staff. Really fantastic. All of the folks from SCCM, Ken Claridge, who actually directs all of the FCCS portal programs, Brian Schramm, Katie and Colleen, who were just indomitable and made sure everything worked and operated well. Really, we had no worries or any concerns. So lots of lessons learned. I think probably the most important one is to just remember that practice in the United States is not the same as practice anywhere else. And you have to be really willing to work on the fly. You can't be so bound to what your slides are or what you were supposed to say. You have to be really at a high comfort level. And in the future, I'd like to see more emphasis on daily patient care and the basics of critical care management, a lot more time on that. Skill developments, particularly related to mechanical ventilation, and bedside time with the teams on the ground. Marina?
Yeah, I mean, that's pretty much it. We had to basically realize how much we had to step back and start from the basics. But I agree. I think having more hands-on at bedside would be great in bringing back some of those. We would come back from a different angle nowadays. Considering that they don't have as many people to work with, they may not have while they may have equipment, they may not be trained on that equipment. So we do have to consider all those things.
Yeah, I would say if we went back and if they asked us what our advice would be, we were there basically 10 days, a day of travel on each side, no, 11 days, a day of travel on each side, 1 day off between all the courses. I would probably say that we'd want to be there for a full 2 weeks so that we could have more time doing rounds at the bedside and really working with them at the bedside, because I think that's really one of the most important things. Yeah. So that would be what our advice would be, I believe. And I know that a lot of you are interested in how to get involved with disaster, how to get involved in war-torn states, how to get involved with resource-limited environments. So I'm just going to remind you that you can always join your local disaster management team. That usually, mine is regional. So I don't get deployed by the regional very often. I also would always encourage everyone to take advantage of the 24 half-hour courses that FEMA offers, and then you become FEMA certified. Then the government can also reach out to you and see if you're willing to volunteer. But most importantly, if you're interested in working within the Society of Critical Care Medicine, the very best way for you to get involved is to join the FCCS committee, volunteer to teach and become an instructor in an FCCS course. You got to get trained to become an instructor. And by the way, if possible, never say no, always say yes, every opportunity if you are able, even when you feel afraid, even when you're uncertain. I would always encourage people to be sure they're going to be safe and not to cause problems for their family or their work, but to always say yes at opportunities that are offered. I will say I'm a little nervous about this opportunity to go to the Sudan, but I'm going to go anyway. And just never give up. Just keep pushing. If you want to be involved, push until you get in touch with somebody who can help you. Try to always reach for people on the ground. Try to always be sure you're associated with the process on the ground, because a sole person going into one of these environments, there's a really danger to yourself and others, and you never want that to happen. So we did have a reunion, 2024 in Phoenix. This is us at our Phoenix dinner. I got a nickname as Barbara McLean, the life of the party, and the person that the whole city of Lviv was going to mourn my leaving, which is completely untrue. It's just because I always look happy during pictures. And SCCM, of course, posted this as a global health initiative showing all of us in our practice and in our work in our skill stations and in our training sessions, and showing the engagement of those who participate. So, Slava Ukraini.
Thank you so much for time and attention, and sorry we over time. I really appreciate the opportunity to share our story and our experience, and if there's time, we would love to welcome questions or any other comments, feedback.
I'm going to come out of this so that you can actually see us better, I think, or we can see you. So that'll be really good. There we go.
Barbara, Marina, thank you guys.
So we're very happy to answer questions. We are 5 minutes over time. I'm so sorry. We had a lot to share and probably still other things we could share, but we'd love to answer any questions if there are any, Kyle.
Of course, of course. I do have one quick one. I just wanted to know, do you guys have follow-up after the visits as far as
Oh, no, because I turned the sound down. Sorry, did you ask a question? I'm so sorry.
Not a problem. No, the question was, as after the visits, do you guys have follow-up with the sites and the hosts to kind of see how things are growing, maybe like a couple months out, and just kind of reevaluate the impact that you guys had?
So I think we have some individual contacts there. One of the residents, Elena, and I communicate quite regularly. I sent a couple of mechanical ventilation books to the residency team. The anesthesiologist is communicating and also communicating with SCCM leaders and MJ, and then Marina.
Yeah, same. We made a lot of contacts, and they reached out to us asking for various protocols to help them implement some of the strategies that we talked about, and then just in general, other protocols that we could share. We met healthcare providers from all over the country, so it's hard to reach out to any particular place because, you know, basically, hopefully it's spread all over. But yeah, we've been in contact with the residents that we met at that particular region center for sure, and following through. And they're doing some of the things, obviously, and and that's what we told them. You know, no, we do not expect you to do all of these things, but even if you just do one of any of the components that we taught you today, you will be better off than you were yesterday, and that's what they're trying. So they were mostly focusing on their sedation choices. Joanna and I, we, basically at the end, everybody was saying no benzodiazepines, no benzodiazepines. So that was our goal. I think, and then they're working on ventilator management and kind of liberating patients from a ventilator and appropriate sedation. Yeah.
Awesome, thank you. And if we have one more that just came in the chat. Is there a certain mode of ventilation that they use, I believe, over there in Ukraine compared to here?
Yes, so they use assist control, volume control ventilation, and I think that's really, really standard methodology for them. And they don't really have, even though they had like one of the most advanced Hamilton ventilators that has, volume support, assisted support ventilation, pressure regulated ventilation, but they really didn't understand those modes. So basically it was assist control, trach, rehab, and really not utilization of pressure support modes or any kind of assisted mode. And I think if you developed ARDS there, you probably were unlikely to survive because they didn't really advance PEEP or understand the advancement of PEEP and how that affected blood flow dynamics and hemodynamics, and don't really have that nuanced capability despite having really a plethora of lung dysfunction, just really standardized ventilation. And probably an important thing to say about that is that when you finish medical, so you do a 6-year program, right? So that's your university and your medical school, 6 years, you apply for a residency that you pay for. and you get assigned to a spot. It might not be what you want, and you basically get thrown into the fire, and you may or may not get well mentored. Although they had some great folks. I'm not saying that they didn't, but the program of education, bedside education, very different than what you see in the United States. So you would get trained in a style, you didn't get exposure to anything else. And so that was one of the benefits, I think, really was in my ventilation skill stations, I talked a lot about recognizing when patients have the capability to transition and utilizing pressure support, doing a weaning trial for 30 minutes and then extubate. And I think that was kind of the theme throughout, and that was a lot of what happened when we were applying at the bedside, because we had one respiratory therapist. He works for Hamilton. He's the one who made sure we had everything we need in terms of ventilators. And thank goodness he was a person that was very open, and he was very, 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 very relevant at the bedside, working with them on ventilation strategies. But this was a whole new world, right? Assist control, volume control, regardless, and not really looking at pressure control methodologies or adaptive support ventilation or other kinds of supportive ventilation that actually could be well applied in that early transition. So I do think one of the things we would probably say is we want to spend a lot more time on ventilation along with sedation and analgesia, and then offloading to reduce delirium and to basically preserve diaphragmatic function. That would be what we'd want to do, go back there.
Yes.
Do you agree?
Yes.
Awesome.
So any other questions?
Just one more that just came in. I'm sorry, in the interest of time, this will probably be the last one, but what parameters did they use to manage mechanical ventilation?
None, not really. They're not really using parameters. They're not really looking at plateau pressure. They're not looking at drive pressure. They primarily are looking at oxygen and CO2 on the blood gas to make a decision about, am I going to increase the respiratory rate? Am I going to increase the tidal volume? Not really using ARDS-NET protocols for protective lung ventilation. So basically just making changes in FiO2, minor changes in PEEP based on the patient's PaO2, and then adjusting tidal volume and respiratory rate, but not really looking at flow rate or I versus C time for CO2 clearance. So very, very, very basic ventilatory skills. And
they train patients very early. They train
them
patients very
so quickly.
Early. So most of their patients were like the ones that we saw. Everybody in the ICU was trached and sedated. So I don't know. That was probably their mode of weaning.
That's how they wean, yeah. But for ventilatory management, they didn't really have parameters to say, okay, like they weren't using an ARDS-NET ladder of FiO2 and PEEP. So a lot of things that we were talking about and exposing them to, I think were really quite brand new for many of them. And, one of the residents said, yep, well, I graduated in June and I'm in surgery all the time now, and I'm just doing whatever the surgeon says and I'm following what he does, and he shows me what to do and I do it, and that's it. And, they're working, they don't have protection like residents in the United States do. So they work every day of the week, and they actually have one 36-hour shift per week, and they make what, $90 a week? They can't even pay their rent. They have to basically live with their parents or live with 6 or 7 people in a one-room apartment.
Their training is definitely much less too. So anesthesiology program after medical school is a 3-year residency program, and then they run the ICU and the emergency department. So their anesthesiology program is they're the intensivist in the ICU and also the emergency department. So their average age for like
and the OR, they're also in the OR.
In the OR, yeah. So they're intensivists who run their ICU could be in their late 20s, 26, 27, 28.
So we call them intensivists. They're not intensivists. Right, they're anesthesiologists running the ICU and the ED and the OR all together.
So, you know, some of them have very little experience, but they learn on the job, basically.
So it all depends on who's teaching them. And I think that's what was so great about FCCS is it certainly exposed them to a different way
Yeah.
of thinking and, you know, really bright, energetic, desirous of knowledge. I mean, the residents were just fantastic. And every bit of information you could give to them, they soaked up. And I think also, I think it is really important to also say that one of the benefits of FCCS is to actually expose and explore the role of a multi-professional team, because physicians there do, you know, they do trach care, they do the suctioning, they manage the CRT. The only thing they're not doing is bathing the patient. Everything else, the physician primarily does. And that isn't to say that they don't have nurses who are completely capable, but that is the way it is there. So I do think that one of the beauties of that is, oh my gosh, look what the physical therapist does. What is a respiratory therapist? And look at him, and look at the nurses, and look at the PharmDs. I think generally they typically have an expectation that physicians are working at a high level. They may not have as much exposure to other professions working at extremely high levels. And I think that's always an opportunity when FCCS goes outside of the United States. Inside the United States, pretty much everyone expects your PharmDs are brilliant. You can't run an ICU without them. Your ICU nurses have a lot of autonomy and they manage patients and they communicate that to you. And you have a respiratory therapist and physical therapists that are operating at high levels. That's not true in other countries. So that is also a benefit, I think, of FCCS, is to explore the importance of those roles.
Excellent. Thank you guys so much for that wonderful insight. It's definitely eye-opening to hear the impact that you guys had. With that, I would like to close out our bite-sized lecture. Again, thank you to our guests and looking forward to another one in October. Everyone, have a great day. Thank you.
Bye-bye, everybody. Thanks so much for attending.
All right.
Let me think.